Welcome to the Maxim Institute podcast. I'm Maryanne Spurdle, the research manager here, and today we're really pleased to have Wayne Naylor here with us. Hello, Wayne.
Hi, Maryanne.
Wayne is the Chief Executive at Hospice New Zealand, which supports our network of hospices. And here at Maxim, we've revisited the topic of end-of-life care in New Zealand. This year we had the paper Interrogating Choice, which was a critique of the unequal choices that Kiwis have in the wake of the End-of-Life Choice Act. And one of the most troubling inequities you find there is that euthanasia is fully funded and it's available everywhere in the country, but access to specialist palliative care and hospice services is by postcode lottery. Now, Wayne doesn't just head up Hospice New Zealand. He's an RN who's worked in cancer and palliative care, and he's held academic and senior nursing roles both here and in the UK. So we couldn't find someone more qualified to talk with us about end-of-life care than yourself. So we really appreciate your time here. Not everyone knows exactly what hospices do, and even those who are vaguely aware of them don't know much more than that they care for people as they're dying. So if you could kick us off by giving us your elevator pitch for hospices and describe how they fit into the wider health system, that would be great.
Sure. So in New Zealand, we have 32 hospice services spread across the country, and they're all based on originally the UK model of the modern hospice movement. They do range in size and what they can provide, but we as hospices take a holistic approach to care. So, and what we actually provide is palliative care. So it's care for people to improve their quality of life when their disease or condition is no longer curable. So we focus on things like managing their symptoms well, providing social support to them and their family whānau, providing emotional support because it's clearly a very difficult time in a person's life, difficult for family and friends to cope. Spiritual care as well is a key part of what hospices do, and cultural support as well. So we take a holistic approach, unlike generally the rest of the health system, which focuses a lot on disease and symptoms and a big focus on cure. So hospices, as a part of the health system, kind of pick up where other health services leave off, which is when a person's disease is no longer curable, and in particular when they're entering the last 6 to 12 months of their life, providing that holistic support with doctors, nurses, a whole range of allied health professionals, particularly social workers, counsellors, and other therapists. And I guess that is one of the key points of difference is we have a real focus on a multidisciplinary team approach and a real focus on the whole person. And that whole person approach includes their family whānau, in some cases their friends or whoever they make up as their family. So across the country, like I said, 32 hospice services. And we do struggle a bit with that postcode lottery, but in the main, you'll get nursing support no matter where you are, usually family or family services, which is our allied health teams, and usually doctors, but not always. So yeah, hospice is providing community-based specialist palliative care.
So where somebody might have contact with a hospice, they could be in a hospital, they could be in their own home. Because I think we think of hospices as buildings that have rooms and sometimes people go to the hospice, but your hospices are working in tandem through community nurses and through hospitals and training people in those places as well, right?
Yeah, it's one of those myths about hospice that it's a place you go to die.
Yeah.
And in actual fact, only sort of 10 to 15% of people who are in a hospice service or across the country in hospice services ever go into a hospice inpatient unit. In fact, a lot of our hospices don't even have an inpatient facility. They might have day services or outpatient clinics, but almost all of the care they provide is in people's homes. So we have doctors, nurses, and family services teams going out into the community every day to visit people at home. Or people are well enough they can come in and do day activity programs or see a health professional in a clinic. So it's really, first of all, it's not a place you go to most of the time. And usually when people come to a hospice, they're not coming there for the last days of life care. That does happen sometimes in the inpatient setting, but usually they're coming there for a short stay in an inpatient unit or just to see one of the team as an outpatient. So yeah, almost everything we do is in the community. And then we have a extension of what we do, which is not directly related to the patients and families in the hospice, but we're providing advice and consultation to aged care providers, into rest homes, into hospitals, to general practitioners in the community so that they can provide good quality palliative care to the residents and patients that they're seeing. We also provide a lot of education, again, into a whole range of settings. A lot of it is into aged care. Probably people in New Zealand may not realise that well over a third of people in New Zealand who die are in an aged care setting. And so it's really important that they can provide good quality end-of-life care, and that's what we help support.
Right. I know each one of your hospices has its own income stream, its own budget, right? Can you explain to us how the funding works for hospices?
Yes. So it's an interesting scenario that we currently have. So hospices started getting government funding about 25 years ago when DHBs came into existence, district health boards. And actually, for a lot of hospices, their contracts haven't changed a whole lot in 25 years. So consequently, the funding that they received hasn't increased hugely. So right now, on average, hospices are about 50% funded through government funding through their contracts to deliver community specialist palliative care services. 28 of the 32 hospices get Crown funding. The rest of the funding comes from the fundraising activities of hospices, and that includes our vast network of secondhand retail shops. There's, I think, about 136 secondhand hospice shops across the country, fundraising events, donations, occasionally bequests, and that year before last, I don't have this year's figures, but the year before last, that was about $112 million that hospices raised and that people generously gave to hospices, on top of the 114 million from the government. So this year, I expect that it's going to be, the costs have definitely gone up. So that gap between what the government funds and what hospices have had to raise is probably going to be bigger. Most hospices have a foundation which provides for all of their capital, because this is another thing that people may not know, is that all of the buildings, the vehicles, the equipment that hospices have and provide into patients' homes from the equipment perspective, that's all funded by hospices. Government funding doesn't cover any of that, so it's grants in some cases, but also the donations, fundraising. The foundations are usually there to raise funds to do the big capital builds for a new hospice or to refurbish the hospice. Everywhere, like your home, needs to be renovated, redecorated after a while. But also, in many cases now, they're giving funds back to the hospice to cover year-end deficits. Anything from $500,000 to $1 million to cover deficits where hospices haven't been able to generate enough funding to meet the needs of their community. And then a big challenge we have with all of our funding is there's no rationale behind it across the country. District health boards just decided they'd give a hospice a certain amount to do community palliative care, but they generally never specified what that was to include and how much they were giving for the different parts of the service that hospices provide. So consequently, across the country, we have a wide range of different contracts for different amounts of money, sometimes specifying services, but often not. So it's quite a confused environment that we're working in, where there's no standard model of funding. There's no basis for the funding, and it's not designed to meet the community need. So hospices do the best they can with the funding that they can generate.
So when the DHBs were set up, what level of funding did the hospices receive? Was it more than 50% at the time?
I think in the early days it wasn't. It did go up, and at one point, actually, it's probably not got much higher than, for total funding, it's probably not got much higher than sort of 55 to 60%.
Right.
If we focus just on the funding of the clinical services that the government wants to purchase, that's about 64% funded. So even when you just look at, a nurse going to visit a person in their home, the government funding covers about 64%, and that's on average. It ranges, and sometimes it's less than 50%. So hospices are topping up a considerable amount just for the core services that they deliver, and then on top of that, they fund all of their own fundraising costs, all of their retail costs, all covered by the hospice.
Yeah. I've seen the stat that for every dollar hospices receive in funding, they provide $1.59 in services. Could you explain how the work that hospice does actually takes the burden off of, say, EDs and other hospital services?
Yes, so there's a report that was commissioned by 5 of our member hospices, Sustainable Funding for Hospices, undertaken by Martin Jenkins. So it's the first time really that there's been a deep look into the broader impact that hospices have on the health system. So Martin Jenkins looked at these 5 hospices, their service delivery, their funding from government and their own fundraising, and what happens to people when they come into a hospice. And so this report purely says that if the government spends a dollar on a hospice, the broader health system and our social benefits is $1.59. And a big part of that is that hospices help keep people out of emergency departments, out of hospital. They reduce the need for GP visits, so people aren't paying out of pocket for their GP. And also the social benefit of people who are bereaved getting back to work sooner, or their children getting back to school sooner. So all of that adds up to $1.59. And then also on top of that, for the dollar that the government pays, hospices top that up by another third. So they actually get $1.54 worth of care provided. So really, the total benefit is well over $3 return on investment if you include the care that's provided, and the hospice is funding a third of that, plus this huge impact on our health system and the cost savings. And alongside the cost savings, we're freeing up resources in hospitals as well.
Yeah, I think when we look at spending on healthcare, often it's seen as we can either spend this and get this, or we don't spend that, and is it worth it? But when you can spend something, like there's going to be a cost there anyway, but the quality of care and the overall cost will depend on what type of care the person's getting. So that Martin Jenkins report was really interesting on that front. Another really interesting thing that came out just this year in July, there was an article in the New Zealand Medical Journal by Catherine D'Souza about the gaps in palliative care here. And if anybody wants to check that out, it's like the briefest, most comprehensive thing I've seen describing the landscape here. She says that international recommendations for the numbers of specialist palliative medicine doctors per 100,000 in population, it ranges from 2 to 4.4 full-time equivalents per 100,000. In New Zealand last year, we had fewer than 1 per 100,000, 0.84 FTEs. And that's less than half, as little as a quarter of the recommended number. And of course, you've got an aging population as well. So we know that number is just going to rise. And as you pointed out, there doesn't seem to be any solid intention to increase, the funding, the training of those who are providing this care. That, for me, was one rough way of describing the state of end-of-life care in New Zealand and the commitment to it. And I've seen you quoted as saying that society sees death as a medical failure. And I think that has implications for the way society cares for those who are dying. Could you connect the dots for us? So how does that attitude play out in how palliative care is or isn't prioritized by the health system?
So I think this goes a long way, well, not a long way back, but a reasonable way back into our history and why hospices came about in the first place. So in the UK, Dame Cicely Saunders, who trained as a nurse, then a social worker, and then a doctor, and is the founder of the modern hospice movement, she experienced people dying very poorly in hospital because they were receiving treatment for cancer in particular. The treatment was no longer effective, and so they were moved to the far end of the ward where they might die alone and with poorly managed symptoms. And she thought there had to be a better way of doing this. So it was, a failure of medicine that we couldn't cure this person. So basically, we can't do anything else. So she founded St. Christopher's Hospice to take people out of hospital into a much more homely environment where there was a holistic view of their care, the understanding of total pain for a person, which is where pain is more than just the physical symptoms. It's the psychological, it's the emotional, it's the spiritual, and the social pain. So working out how you assess that and how you manage all the different aspects of the person, and that's still the basis of hospice. And actually, palliative care came along a little bit later. And I was actually at a presentation yesterday. A palliative care doctor was talking about this, and palliative care was a term coined in Canada because in Montreal actually, because hospice in French describes I think a house for poor people basically, and they didn't want to call it hospice, so they called it palliative care. And nowadays we refer to it as palliative care, and that's what hospices do. So I think I think what happened is the hospices kind of picked up the dying people, and they sat outside of our mainstream health system. And I think that we've kind of got a bit stuck with that place outside of mainstream, and so death has been pushed out to hospice in our country into aged care as well. Like I said, over a third of people in New Zealand die in aged care. And to a lot of people, that's quite invisible as well, actually. And another whole area of concern for New Zealand, the aged care sector. But what we need to do now is try and bring death and dying back into our normal conversations, because we don't like to talk about death and dying. It's become very much a medical event and a failure, and it's scary as well because it brings into harsh reality our own mortality as well. So we don't want to talk about death and dying because it just reminds us that at some point we're going to die. And unfortunately, the death rate in New Zealand and in all other countries is 100%. So at some point it's going to catch up with us. So I think that we have a job to do now, bringing death and dying back into community conversations, into our own conversations, and as a key part of our health continuum, so that we have a health system that works from birth to death and truly meets the needs of everyone in our community.
I think one of the interesting things about New Zealand's story is that we actually were on the trajectory to do quite well in providing palliative care. This survey in 2015, we were ranked third in the world for the quality of our palliative care. By 2021, we were 12th, and the most recent numbers were 15th. And actually, we were rating highly, I see, is things like research and education. It's really on the ground stuff where we're, mediocre. There's a private memories bill addressing palliative care that's been in and out of the biscuit tin over a number of years, mostly out lately, sponsored by different MPs. And what it would do was require the Minister of Health and Health New Zealand to ensure that access to good end-of-life care is more equitable, setting targets, reporting. Do you think this kind of legislation is part of the solution? And with or without legislation, what do you think Health New Zealand should be committing to get to that level of care that would be, equitable and give everybody the option of accessing it?
So I think, firstly, the legislation would be good. I know that it's currently not in the tin because it's not an election priority. But in saying that, I believe it will be a part of the health manifesto for the party. So as New Zealand First, who is sponsoring it, they are going to make palliative care part of their health manifesto, and some other parties will as well, which is great. So yes, it'll be good, but it's not essential. What we need is a commitment from the government that palliative care is seen as a key part of our health system. And it's included in all of our health strategies, because often it's not, or it's barely mentioned. And it gets funding that's proportionate to the need in our communities for specialist palliative care, which is what hospices do, and it's also provided in hospitals, but also generalist palliative care, which is provided by a whole range of people in all sorts of different settings, like aged care, many hospital wards, if not all of them, general practitioners, etc. There's a real lack of information around what is happening in all settings for palliative care, actually. So right now, Health New Zealand is doing a lot of work on this. It's the first time since 2015, really, that we've had a considerable amount of work happening in the palliative care space at a national level. So Health New Zealand has its National Palliative Care Work Programme, been running for 2 years to design new models of care. And alongside those models of care, there should be new funding models, new and more consistent reporting requirements, and also a workforce strategy. That will probably play out in the next 2 years, as long as our government, and even if the government changes, commits to seeing that work program through and implementing the recommendations of that work. There's been an awful lot of work done, still work happening. A lot of people from across the health system have been involved, lots of clinical staff and support staff across from a wide range of sectors. And we currently also have another project that Health New Zealand is running to help them understand exactly what it is that hospices do, because they just don't know. And also how much it really costs to deliver hospice services. That's another thing they don't know. They have a pretty good idea of how much they contribute, but they don't know how much hospices are contributing to the cost of delivering those core services. So it's quite a bit of work happening, which is exciting. And I was involved in quite a lot of the work in over the 2000s and kind of up till 2012. 2015, there's a lot going on in New Zealand around palliative care, and then post 2015, it all stopped. And we've pretty much been standing still or going backwards, and many other countries have been overtaking us because they are doing a lot of active work to progress palliative care in their countries. So they have national strategies, they have funding, they have workforce training. One of the big areas that we've dropped down on in the most recent global review was pediatric palliative care. We don't have sufficient provision of palliative care for children who are dying in New Zealand, which actually is a bit disgraceful. We don't have large numbers of children who are dying, but that's a worse postcode lottery than adult palliative care.
Right.
And we could fix that quite easily for a fairly small amount of money, but that's another thing that needs that commitment from the government and then from Health New Zealand to implement it.
Was there anything in or around 2015 that kind of stalled the progress we'd made, or was it just a...
No. So the key things that happened there was a person working in the Ministry of Health with a focus on palliative care, and that role was disestablished, I think even earlier than 2015.
Okay.
And we also had the Palliative Care Council, which was created by Cancer Control New Zealand, which existed then. And I worked for Cancer Control New Zealand doing work with the Palliative Care Council, and we did a lot of the initial work to understand the need for palliative care in New Zealand and what was being delivered at that time. It's quite difficult. We had pretty good information from hospices, but not anyone else. So we were providing advice directly to the Minister of Health. We had a few different ministers over that time. But in 2015, the government at that point decided that they had fixed cancer and they no longer needed Cancer Control New Zealand. So they disestablished Cancer Control New Zealand and disestablished the Palliative Care Council. So there was no one with an oversight of what was happening at government and ministry level, and no one driving any work program. And so it all just kind of stopped. And it didn't take long, I think 2 years before another government realised, actually, we're not doing that great at cancer. So they've now re-established the Cancer Control Agency. So there's a very small gap when they realised that wasn't actually, they hadn't solved the cancer problem. But the Palliative Care Council was never re-established, and nothing's happened since then, until 2 years ago when Health New Zealand, in its infancy, appointed their first palliative care senior advisor. And now they have 2 staff focusing on palliative care and a slightly bigger team doing work on the whole palliative care work program.
Right. And you think that's going to send things in a better direction based on movement so far?
I think there's a good chance that it will if it continues to have good support from the government. And we know at the moment that the Minister of Health, Simeon Brown, is interested in palliative care. In the most recent letter of expectation to Health New Zealand, he did put in there that he expected them to, this is my own words, I can't remember exact wording, but to sort it out the inequity of access and the workforce challenges currently being experienced by palliative care in New Zealand.
Right. Do you have, this is a final question, any suggestions for those of us who are not MPs, who aren't working in medical roles? What can we do to support what hospice does?
If you ever have a chance to talk to an MP, that would be really great, just to get that message sort of filtering back to the Minister of Health. If you feel very strongly about the lack of or the postcode lottery around palliative care, you can write to the Minister. If you want to support your local hospice, you can do things like volunteering. We have a huge army of about 10,000 volunteers across the country, and hospices can't operate without their volunteers. It's millions of dollars worth of free labour that they get to help run their services. But you can also shop in a hospice shop, donate to a hospice shop, make a donation to your hospice, leave a gift in your will to hospice. At the moment, we're running our annual farmers campaign, so you can buy a Christmas bauble at your local farmer's store, and you can also make a donation there and put a little special card on the Christmas trees of remembrance to remember someone who's no longer with you as well. All that money goes to the local hospices.
Oh, lovely. Really appreciate your time today, Wayne. Thanks so much for being with us. And we'll be keeping an eye on what goes on in this space.
Great. Thank you very much. Really appreciate it, Maryanne.